Rahman Rahim. My dear fellows, students, my colleagues, all those who are appearing in the postgraduate examination, and all my family physicians who are attending this tutorial are welcome, because we are dealing actually with the basics, what is I'm called as, and basics are essentially needed in the pathogenesis of this mechanism of a disease process is concerned. As disease is concerned, I have already said previously that if somebody wants to become a confident physician or internist or clinician, whether surgeon or gynecologist or of high specialty, then one should know about the clinical anatomy, the clinical physiology, the clinical biochemistry, and applied, what is known as pathology, special pathology, and also the clinical pharmacology, or you can say the therapeutics, along with the regional medicines, that is ENT or eye or whatever it is, the basis of that. Not all, one should know. And if you add these things, all of them, along with the clinical scenarios, then it is what will be known as internal medicine. So it includes all the important modules. And one module is infection and the disease, which I am actually on the way of my talk. And I have already given about 6 tutorials on this. This is the 7th one. And I am taking one by one. So it may be beneficial to the surgical and allied persons also, because they have been asked about it. I am Professor Sayyid Ali Haider, and I am visiting professor of medicine at GSMCU, that is Jinasan Medical University, Karachi. And I am taking online lectures. Because of my poor health and because the higher authorities of the higher institutions, they do not like to invite me. Why they are not inviting me for the physical appearance in the lecture hall, I don't know. But it was predicted by my supervisor in 1998, that he said that when I will be retired, then you will be gone. And I go, why? Because he said that I had tolerated you for 7 years or 8 years with me, because I am a big heart. Nobody will like you in future. And I go, why? The thing is this, that he said that because you worked hard, you worked diligently, you can teach very, very cautiously, and you want that every student must be taught. This is why the people will don't like you for any employment in the future. He was correct, because every institute at one time, they have an objection that why I am taking these lectures for more than the time allowed. The time allotted is 10 minutes. For example, for this lecture, Streptococcal infections. You are not completing this lecture in 10 minutes. So you are not a good teacher in this sense. Time relationship, time management. I said to them that every student in the hall should understand what I have said. I am not actually leading the slideshows. I am sitting among them and try to deliver my knowledge to them. This is my actually sin or guna or whatever it is. So I was not being called by other institutes afterwards. Only the Jilasa Medical University still maintaining my visiting professorships. Because everyone wants to become the head of the department who is retired. The thing is this, actually one should know the basics. Otherwise, he cannot understand the pathogenetic process. When he cannot understand the pathophysiology or pathogenesis of the disease, how can he become a good clinician? I don't understand. So that is a task of my burden. Shoulder, there's a burden. To talk about these things. Sharing my experience with another person who was appearing in FCPS Part 2 surgery in 1996. When he came back, he abused the examiners. So I said, why you are abusing the examiner? He said that the case was of the hydrated cyst at the end. And he has asked me, which is the phylum of this, what is the parasite, phylum, family, genus, species, life cycle of the Echinococcus granulosus. And along with the recent advances of pharmacological advances in the management of the Echinococcus granulosus, hydrated cyst. And the other things he said to me that the pathophysiology, the pathogenesis was asked. As far as the surgical part is concerned, I have answered all the questions. But as far as this is concerned, I was not able to answer it. If they are fool, he said, no, we are fool. We have actually forgotten the basics. Without basics, how can you manage these cases? I don't understand. They are not at the fault. The examiner never become faulted. Remember, you are at some stage of the problem and you should increase your knowledge. You should not count how much attempts you have been done. More are the attempts, more are the knowledge. More are the knowledge, more are the beneficiary. And you can serve this country well. This is my slogan. So gram-positive cocci, streptococcal infection was done. Now this is another streptococcal infection, that is the gram-positive infection with cocci in chains. Strep means chains. Strep means in groups. Now streptococcal infections are very, very common infection you will see. Characteristics of the streptococci, the gram-positive cocci, their size is 1 micrometer in the high microscopy field. Chains or pairs rather are seen, look like this. And they are gram-positive, means it is seen like this. Non-spore forming, they are not forming the spores. They are facultative anaerobes. They need some oxygen, not high oxygen. And they are fastidious organisms, means they are present in your body. At some places as commensal, and they are catalase negative. In the previous lecture, Staphylococcus aureus, I said that they are grouped in the catalase positive and catalase negative staphylococci. Depending on the properties of the catalase is concerned, the streptococcal infections can be discussed. In the same fashion here, the streptococci. Now, the thing is this, every organism, it is difficult in the clinical microbiology, this is. You should know about you should know which type of the microorganism it is. Is it bacteria? Okay. Is it gram positive or gram negative? It is coccus or bacillus. Then afterwards, it will be asked like this: that what is the grouping of the streptococca, whatever it is. Then typing, then forms. You have already heard about it. In the same fashion, this is a very important part of the epidemiology is concerned. Because every streptococcus is not a dangerous problem. Every pneumococcus is not dangerous. Some of them, which are classified as invasive described upon the types actually and the forms and the genotypes. So this is a sub-classification in this session. For what is important in the streptococci is that it should be classified according to this. First of all, the oxygen requirement, whether they are anaerobic, that is Peptostreptococcus, is one form of the streptococcus, or facultative anaerobic or aerobic, that is some oxygen is needed, at least, surrounding oxygen. But they can survive in low oxygen anyway. Then on the basis of the culture media, agar, blood agar, they can be classified on the hemolysis of the blood, which is present in the agar, whether the alpha hemolysis or beta hemolysis or gamma hemolysis. After doing the alpha, beta and gamma, they are then subclassified by what is called the Lensfield grouping. The grouping is done based on the C antigen. They are classified group A, group B, group C, group D, and E also. And then the Griffith types afterwards. For example, it is Streptococcus A. For example, okay, fine. For example, it is beta hemolysis. You say that beta hemolytic, it is beta hemolytic, but its group is A, group A Streptococcus. Then they are asking you, this is Lensfield classification. What is Griffith typing? As an epidemiologist, they will ask, it is type 1 or type 3 or type 7 or type 8. Now, whenever the examiner asking these questions, the people are confused. It is actually their right to ask you, because you are becoming the assistant professor afterwards of the surgery or the medicine or the gynecology or the pediatric, etc. The hemolysis and the blood agar. Is alpha hemolysis means partial hemolysis, green discoloration around colonies. An example is the Streptococcus pneumoniae and Streptococcus viridans. Beta hemolysis is complete hemolysis. It is clear zone of hemolysis around colonies. Lensfield group A and B are classified under this beta hemolysis. Streptococcus pyogenes and Streptococcus agalacti. They are two very important organisms in this group. And then afterwards, coming to the gamma hemolysis, there is no hemolysis. You classify under group D or E nowadays. It is no hemolysis, means alpha and gamma hemolysis. Enterococcus species are there. Enterococci actually are the streptococci, remember. Enterococcus species are streptococci. They are under the group D. They are alpha hemolytic, gamma hemolytic streptococci. They are asking these questions. This is easy to remember. Streptococcus pneumoniae and returns are alpha hemolysis. Beta hemolysis, it is actually complete hemolysis, group A and B in this Lansfield grouping, Streptococcus pyogenes, Streptococcus agalacti, and gamma hemolysis is group D, where no hemolysis occurs. Enterococcus, very important infections at one time. When you will learn about the specific infection of the intestine, etc., or endocarditis, etc. The enterococcus is a very important infection. Now this is the alpha hemolysis, partial. Beta hemolysis, complete. And gamma hemolysis, no hemolysis. The colonies are seen here. Beta hemolysis, complete. Alpha hemolysis, partial. And last of all, on the right side, there is no hemolysis in the colonies. Lansfield group, Streptococcal Lansfield classification, group A, B, C, D, and E, etc. Classification based on the C carbohydrate antigen of the cell wall. 20 Lansfield groups from A to H and A to B have been described by the epidemiologists, one or more species per group, as the species are concerned. The group A are further subdivided, that is Griffith capping. For example, they are typed like M, T, depending upon which protein they have, M or T or R. And there are 80 serotypes in this fashion. And the genotypes, further subclassification for the epidemiologists are concerned. Well, you should understand the way they are classifying. As far as group A is concerned, Streptococcus pyogenes, group B is concerned, Streptococcus agalacti, group C is Streptococcus equimotus, and group D is Enterococcus, and other groups are also present. But the different names are there. Like, for example, the Streptococcus pyogenes, Streptococcus agalacti, Streptococcus equimotus, Streptococcus equimotus with Streptococcus uva, etc. There are Enterococcus faecalis, very important organism for the endocarditis and UTI. And you'll see when we will be discussing the UTI, Streptococcus sanguis, Streptococcus mutans, is important in the dental surgery, and Streptococcus pneumoniae, which is actually pneumococci. Now, this is caused by the Streptococcus pyogenes. Now, group A, this is group A, and this is beta hemolysis. Suppurative infection they are non-invasive pharyngitis, and they can cause tonsillitis and otitis media, mastoiditis, rarely meningitis. Pyoderma or impetigo contagiosa, secondary inhibitors. Localized pus-producing lesions usually occur on the face, arms, or legs, or what is called compartment syndromes. Invasive means they are causing bacteremia or septicemia. They are localized infections. Streptococcal pharyngitis and tonsillitis. See how the tonsils are inflamed and there is membrane is formed, pussy discharge coming out. Impetigo contagiosa, see under the chin, crusty lesions, shiny lesions, honey, just like a honey. And suppurative type of the lesion, invasive type, are the strep erysipelas. We'll discuss afterwards, because people don't know about this condition. This is a diffuse infection of the skin, involves superficial lymphatics, well demarcated borders, but it will invade the blood. Cellulitis again is the infection primarily caused by the Streptococcus, secondarily caused by the Streptococcus, subcutaneous tissues, and is spreading. Now this is erysipelas in the face. You see these erythema under the lower lip and on the cheeks and on the chin, shiny lesions. Cellulitis here, very common infection in immunosuppressed patients or in the after trauma or in the cases of diabetes mellitus, subcutaneous infection. Then compartment, it will invade inside, then it can cause carbuncle and it can cause the compartment syndrome, etc. Now, toxin-mediated diseases, actually the exotoxin or endotoxins relating with this, we got the scarlet fever, we will discuss it in detail in the next lecture. And necrotizing fasciitis. Necrotizing fasciitis is pyogenic exotoxin produced by some strains of the Streptococcus pyogenes. It can lead to the disseminated intravascular coagulation. So necrotizing fasciitis is a disease which can cause septicemia or septic shock. Then again, is a very spreading infection from elsewhere in the body. It is streptococcal toxic shock syndrome. It can cause the septic shock, it is septicemia, sepsis, septic shock, and then leading to the MODS or etc. There is multiple organ dysfunction syndrome. Scarlet fever will be explained in detail in the next lecture. It is a misnomer now, and in England and Europe this is a very important disease. Necrotizing fasciitis you have seen in surgery. That is, the necrosis occurs of the skin and subcutaneous tissue, and fascia, which are dividing the muscle in compartments. Superficial fascia or the deep fascia, they are also necrosed. And that the compartment syndrome occurs, and they should be surgically managed. Toxic shock syndrome, autopsy cases of streptococcal toxic shock syndrome are seen: swelling, erythema, hemorrhagic, bully, subcutaneous and muscle degeneration, bleeding, and swelling of the muscles, no gas in the CT images, because non-gas fluorescein. So this is putrefaction which is seen in the body afterwards, after the death of this patient in a sepsis. Non-suppurative complication or sequelae, they are non-suppurative, but they are dangerous and very important infection, rheumatic fever, and one is called as rapid and progressive glomerulonephritis, that is acute glomerulonephritis, proliferative glomerulonephritis. Again, these two diseases should be discussed in detail in other tutorials. Now, pathogenesis and virulence factors are the structural components. M protein inhibits the phagocytosis of the bacteria. M protein. Lipoteichoic acid helps in the adhesion of the bacteria. Capsule, there are the cornflakes bacteria. That is why they are important. Enzymes they are secreting are streptokinase, fluolysin, and hyaluronidase and deoxyribonucleases A or B. So they can be detected by the anti-streptolysin titer ASO titer or anti-hyaluronidase antibody, or by the anti-fibrinogen antibody, or anti-deoxyribonucleases A antibody, or anti-deoxyribonuclease B antibody, especially speaking for the rheumatic fever is concerned. Now it is facilitating the spread of the streptococci in the tissues remotely. Now paragenic and erythrogenic exotoxin hemolysis. It is a paragenic infection, it causes bacteremia, it causes the fever, it may be a localizing sign and it may be non-localizing or focalizing. Now hemolysin, streptoglycin O, is oxygen labile and antigenic, it is. And streptoglycin S is also present. And they are the serum soluble. Now how they are invasive, how they become a novel type of microbial or why it is so virulent, because of the structural components and enzymes and paragenic, erythrogenic exotoxins, and because of the hemolysis. That diagnosis, throat swab, pus swab, or local swab, whatever you taken, it should be stained and it should be gram stain, it should be cultured with the blood agar, so the alpha and beta and gamma hemolysis, and then go for the grouping of Lancefield. Bexiticin sensitivity. Now, bexiticin is an antibiotic which is used locally, actually, basically, in our country for presumptive identification of group A. Distinguish between Streptococcus pyogenes from other hemolytic streptococci. Streptococcus pyogenes sensitive bexiticin, giving zone of inhibition around disc. The first thing they will do is a bexiticin. If the bexiticin actually is good and it will inhibit the culture, it means that it is group A. It means it is group A. It is beta hemolysis. Differentiation of beta hemolysis streptococci with the Lancefield classification and bexiticin. Afterwards, you will go to the bexiticin susceptibility test, and then we go for the CAMP test, the CAMP agent actually, which we are using specific for the important organism of group B, which is causing the endocarditis, enterocolitis, UTI, and so on. Agalacti, Streptococcus agalacti. It is in the group B, and the normal flora of the genital tract in women can cause neonatal meningitis. Problem is with this is Streptococcus agalacti. So vaginal swab will be taken for this test, the CAM test. The group B streptococci produce the extracellular protein. It is called CAMP factor. It is the theory behind it. The CAMP agent factor acts synergizing with the streptococci, not streptococci, streptococci beta lysine to increase the lysis of the RBC. Rapid hemolysis occurs in this case. Slow hemolysis, complete or partial or not. Here it is complete hemolysis in a very, very small time. This is called CAM test, which can be done in certain labs. Because Streptococcus agalacti is an infection which can cause the pelvic inflammatory disease, the endometritis. It can cause septicemia afterwards, and in the newborn babies it can cause the meningitis. This is the CAM test, and its principle has been described. The Christie, Atkins, Munch, Peterson test is this to identify group B Streptococci agalacti, specifically speaking, because it is associated with the Streptococcus aureus, which is the primary invader, and it is a dangerous infection in the gynecology. The summary of my tutorial is that the streptococcal general character should be known to you. What are they producing the disease? They are producing the disease. Which diseases? What is the classification of Lancefield? What are the toxins and enzymes of the streptococcal pathogens? What are the infection sequel? Okay. The clinical scenario, that is, and lab diagnosis and management with the empirical antibiotics should be given which are sensitive to the streptococci. There are a lot of beta-lactam antibiotics and also the macrolides, the fusidic acids, and nincomycins. These are the very powerful anti-streptococcal agents, gram-positive against gram. And some of the third generation fluoroquinolones now they are using for it. I think this is a very brief account which I have given about the streptococci as a fundamentals of the streptococci, basic knowledge regarding it. One should understand, please try to understand that in the examination, clinical examination of FCPS is concerned, or any fellowship examination, or higher examination, every question can be asked. What is Lancet grouping, what is graphic typing, etc., etc., etc. Why Streptococcal is important, why Enterococcus is important, and how they are spreading, why they are causing necroplastic fasciitis, why, what is the pathogenetic mechanism behind it. وما لنا إلا البلاغ. السلام عليكم ورحمة الله وبركاته.